So much of the history we'll be discussing today is just really moving on to the Great Society and a neoliberal backlash. Can you guys see, whoops, see this? Yeah, good. So our objectives today, if we have internet, is where did Medicare and Medicaid come from? Want to touch on what happens when you have such federal services in the setting of economic hard times, something called stagflation of the 1970s, which allowed these libertarian neoliberal policies to come into place. What happened following deregulation of the Reagan years, and as you're just talking about, how uninsurance became a serious problem and medical bankruptcy prevalent, and how the policy trap tends to stall reform. So the fight for Medicare. Remember that 50% of seniors back through the 50s and early 60s, as well as 50% of the disabled, did not have insurance for medical care because they were felt to be a bad risk by commercial insurers. Insurers could not cover them. Many people went without coverage as a consequence. And there were efforts throughout the 1950s and 60s that, by the way, taxes were 90% on the very wealthy, which is a striking number, but that is a reality. There was a federal surplus as a consequence. And there are modest bills that were proposed, including those by Senators Forant and King, which was really the forerunner of Medicare. It recommended coverage for seniors simply for hospital care, no other care, uh, as funded via the Social Security insurance or the Social Security agency. It would not be universal insurance, and it was modest perspectives. This was supported by labor. They'd love to have it for their parents, but labor, again, was not in support of universal health care. 1960, John F. Kennedy faced a much less polarized electorate. Again, we talked about this the other day, yesterday, which had seen efficiencies of big government and safety nets. And he was swept into office. And in 1960, he was facing a conservative Congress, and Senator Cares and Mills enacted a law that is the precursor, actually, of Medicaid. And this was a limited provision of care for the poor based on income. So that means it was means tested. It was administered by a state only if that state so desired. Only 28 states adopted it, and only 1% of the elderly actually received benefits, and very few of the poor received benefits as well. So it was a modest and fairly incomplete bill. JFK, as you know, was assassinated. Lyndon Johnson took office with his hand on a Bible and an airplane with Jackie Kennedy behind him. He thereafter, the following year, was elected in a landslide, and a blue wave took both houses of Congress, such that the stage was set for actual reform. I'm going to hide my thing here. Um, and the AMA, once again, of course, vigorously opposed any governmental health insurance and set about trying to sway not just the populace, but also physicians to vote against Medicare. They had Operation Coffee Cup, where they had leaders go out to have coffee clatches of the wives of physicians to speak about the evils and dangers of Medicare. And this guy you might know, Ronald Reagan was hired. He was to become governor of California, but at this juncture, he was still a personality and an actor. Whoops, I'm hoping to be able to get this thing to work because it's worthwhile hearing. I have it on my, good. So let's listen to Ronald Reagan's perspective. This is the origins of neoliberal thought.
My name is Ronald Reagan.
Yep.
One of the traditional methods of imposing statism or socialism on a people has been by way of medicine. It's very easy to disguise a medical program as a humanitarian project.
Can you hear
Most
this?
people are a little reluctant to oppose anything that suggests medical care for people who possibly can't afford it. James Madison, in 1788, speaking to the Virginia Convention, said, "Since the general civilization of mankind, I believe there are more instances of the abridgment of the freedom of the people by gradual and silent encroachment of those in power than by violent and sudden usurpations." Now, in our country, under our free enterprise system, we have seen medicine
Dr. Dolkart, since you muted, we can no longer hear the audio from the video. Unless you guys can and it's just me. No? Okay.
I can't.
I think he might have disconnected again.
Oh, me. Well, I don't know, because the video's still going. Mm. Dr. Dolkart, I'm not sure if you heard us before, but since you muted, we were unable to hear the audio.
determine a man's place and his working methods, determine his employment.
You didn't miss
Here's
much.
a
It's
short
the
step
last.
to all the rest of socialism, to determining his pay. And pretty soon, your son won't decide when he's in school where he will go or what he will do for a living. He will wait for the government to tell him where he will go to work and what he will do. In this country of ours took place the greatest revolution that has ever taken place in the world's history, the only true revolution. Every other revolution simply exchanged one set of rulers for another. But here, for the first time in all the thousands of years of man's relation to man, a little group of men, the founding fathers, for the first time, established the idea that you and I had within ourselves the God-given right and ability to determine our own destiny. This freedom was built into our government with safeguards. We talk democracy today, and strangely, we let democracy begin to assume the aspect of majority rule is all that is needed. Well, majority rule is a fine aspect of democracy, provided there are guarantees written in to our government concerning the rights of the individual and of the minorities. What can we do about this? Well, you and I can do a great deal. We can write to our congressmen, to our senators. We can say right now that we want no further encroachment on these individual liberties and freedoms. And at the moment, the key issue is we do not want socialized medicine. If you don't, this program, I promise you, will pass just as surely as the sun will come up tomorrow. And behind it will come other federal programs that will invade every area of freedom as we have known it in this country. Until one day, as Norman Thomas said, we will awake to find that we have socialism. And if you don't do this, and if I don't do it, one of these days, you and I are going to spend our sunset years telling our children and our children's children what it once was like in America when men were free.
So, does any of that sound familiar in the world we live in today? These accusations of national health care reflecting, communism. Actually, not even using the word socialism anymore. Somehow it's now muted into communism. And this is striking, but as we'll see, this strain of sort of red baiting, creating a bogeyman of socialism, affecting all of our lives, and bringing down America, in simply as applied to non-socialized healthcare. It is actually just an insurance entity. Again, socialism really refers to government directly funding the medical system. So this was fairly effective, I guess, to some extent. but not bought by a populace in a simpler age. Um, so again, Johnson was elected in a landslide. We had a blue wave in Congress. Medicare was passed as based on the original Thornton King bill, but expanded somewhat. And this was called the Great Society. So Medicare, and again, you're going to hear more details about this from Dr. Malik. I'm going to go through this relatively quickly. But essentially, it was federal coverage for health care for all seniors over age 65, regardless of income, regardless of their medical history. Briefly, and you're going to hear more about this, Medicare is broken into two parts. Well, now it's broken into four parts, but at that time it was two parts. Part A, simply hospital coverage. It was funded by 1.45% tax earnings on the employee and the employer. Part B is in reference to outpatient care and doctor's fees, and this was funded by premiums by someone if they subscribed to Part B, not mandatory, as well as general federal revenue. One of the major flaws of Medicare passed in 1965 was a demand by the American Medical Association to get on the representatives and senators, such that they insisted that doctors were the ones to set fees. There should not be any government regulation of prices. And as we will see, that is not a great way to set up a system. And it was a compromise to allow passage, but an ongoing flaw. Medicaid, by the way, came up at the last minute during reconciliation when both houses get together to pass and create an act. Came up at the last minute when conservatives accepted and added actually that version of the Care Mills Act to provide coverage for the poor, those with low income. Again, it would be means tested and provided by each individual state. By the way, many of your patients on Medicare are dual eligible. If they have in poverty, they are eligible for both Medicare and Medicaid. In some interesting aspects of the bill, Medicare was arising during the initial efforts at civil rights, and it spurred the racial integration of waiting rooms, which had previously been segregated, and hospital floors and practices. It made payment by Medicare to healthcare providers conditional on desegregating such practices. And there's Harry Truman, who had proposed his fair deal back in 1945, who's getting his first Medicare card as Lyndon Johnson signs the Great Society. By the way, you guys we're contending with things like Zoom and internet and AI. Medicare was implemented and enrolled 19 million seniors simply on paper. You had administrators who went to work getting the data processing done and configuring things so that 20 million people could get on Medicare within a year. Medicare was expanded subsequently, by the way, to include dialysis. Your patients on dialysis or end-stage renal disease will be on Medicare. It was expanded in terms of Part B to include physical therapy, speech and chiropractic. Again, with increasing medical needs and advances, it assumed increasing responsibility. I'm going to go again through this briefly. What the experience has been with Medicare is highly efficient administration. Costs are about 2 to 3% for overhead. It's universal, and initially it was portable between states. You could be anywhere in the country and receive coverage. The coverage would be predictable. There's no prior authorizations built in traditional Medicare. It would be a particular new streptokinase or thrombolytic or a new CAR cell, T cell CARs for cancer. As long as there is scientific evidence of its efficiency, it was covered and without delay. It was automatic via Social Security benefits for Part A. And Part B, again, there were compromises made with the private insurance industry to cover the percentage of the 20% that Part B did not cover for outpatient services, but those are called Medigap. Sorry, this is going to be gone over in more detail. I'm just touching on it now. But the provision of that 20% coverage by a private insurance was guaranteed when you first applied to Medicare, if you so wished. This is the software on paper to get things covered. What happened subsequently? Well, medicine advanced. We talked about dialysis. We talked about new chemotherapies. We talked about coronary care units developed during the 1960s in response to how we ate and how we smoked. And the cost doubled between 1966 and 1972. Some of that was from increased services and advances, but a lot of it had to do with unregulated fees. So basically, a hospital could determine how much it was going to charge for a service, and they were basically charging on a per diem basis, a daily basis. So that was an incentive to keep the patient in the hospital, perform what was called the bowel run of the stars. Anybody hear that? Basically doing a barium enema, keep the patient in for 3 or 4 days to do the prep, and then there was no colonoscopies at the time, and then perform a barium enema. Well, that could be done at home, but the hospital made more income by doing it. So there was really disincentives to do efficient care and incentives to do excessive care. Things were felt to be, these are customary and prevailing fees, so that's why we're charging what we're charging. There was a lot of resistance by government, but the AMA remained strong and said that there's no such thing as an overcharge, only fees that vary from low to high. So now again, this is a dilemma today. You'll see that an MRI may cost vastly different amounts from one side of a city to another. Again, this is unique to America. But as an example from the 1960s and 70s, the cost of a mastectomy in one part of the country might be $280 and $1,200 in another. So these are some unique issues. What were some of the problems with Medicaid? Well, as you might know, even to this date, it's often underfunded. There's low clinician reimbursement. And if you're trying to eke out to pay off your medical school loans, it's often not accepted by doctors. It's not mandatory that it be accepted. Because it's state by state, it's variable state funding. The federal government will match the state dollars provided for Medicaid, but some states don't want to provide much for what would be considered the undeserving poor. There's societal and professional bias against folks whose life events have led them to not be able to afford medical care. I'm hoping that's changing, but that's also something that's prevalent throughout the neoliberal backlash. So these were instituted. People were pretty happy with their health care. I think variable of this provision of Medicaid, but the 1970s saw some new events. So something called stagflation. And what this picture is demonstrating is a shortage of gas. OPEC, which was the provision of petroleum producers, came together and cut off funding due to problems in the Middle East. There was a sudden recession due to lack of funding. Along with that recession came inflation, something that was called stagflation, and the economy suffered greatly. The other thing happening during that day was the Vietnam War. There were social divisions. War with the the Cold War with the Soviet Union continued. So there are lots of problems going on. We saw wage freezes and actual price freezes were transiently engaged in 1971. I mean, that would seem to be unheard of in the current age in which we're living. But Nixon, who was a conservative president, felt that that was necessary to implement. It was a different time. During this time, with rising healthcare costs, there were actually bipartisan ideas to initiate a national health insurance. There are many different plans. Whether it would come to pass without Watergate, who knows? But Nixon left office after Watergate, and those plans were extinguished. What happened during this period of economic stress instead was funding for nonprofit HMOs. So we talked about the philosophy of health maintenance organizations with capitation and preventative care and basically ratcheting down of excessive costs based on the exclusion of going to outside care, going only to the medical group that you were signed up with. This was based on Kaiser Permanente, which again provided effective care and cost-effective care. Nixon was from California, as this was before he left office, and the HMO Act was passed in 1973. This basically provided funding to community-based nonprofit HMOs. And it's interesting, again, this is a society that saw Blue Cross Blue Shield community-based. There were local boards. It was not national corporations. So these HMOs were allowed to offer their insurance to companies within a particular community, and it was mandatory to be able to offer it, not to accept it, but to offer it for any company that had more than 25 employees. And that would compete with the private insurers in the employee-sponsored insurance markets. I will share with you that I worked, as I mentioned, when I left my residency, I worked at a small community-based HMO. Again, philosophy, culture of a practice is the most important element of how that practice will deliver care and what your role in it will be. And I will share with you, this is Jim Squires, who is a surgeon who worked with an infectious disease doc to form an HMO in the town of Nashua, New Hampshire. And when that HMO was accepted by one of the hospitals, 50% of the doctors left the hospital in objection to such a pinko socialist conception as the nonprofit HMO. These HMOs actually really pushed and advanced healthcare in many ways. They were the first practices to use physician assistants, diabetic education. There are a lot of other things that we take for granted now were actually implemented with such practices. Well, 1970s also saw the rise of the Heritage Foundation. This was a think tank founded by Paul Weyrich and Joseph Coors from Coors Beer. And the mission was to promote public policies based on principles of free enterprise, limited government, individual freedom, traditional American values, and a strong national defense. And again, the conceptions included markets regulate themselves, everyone gets what they deserve, unions distort markets and impede a formation of a merit-based hierarchy. They proposed that a government was incompetent, despite evidence to the contrary. They clearly felt that taxes and regulations should be cut, public services and public goods should be privatized, and seeking equality is counterproductive and morally corrosive. That's taken directly from some of these writings. And that is the world, alas, that we confront today. The origins of this came from a variety of thinkers. Milton Friedman wrote back, and Milton Friedman came to regret some of these things, and he wrote about how public good actually was not amenable to market forces. But in his earlier writings, he writes, few trends could well, actually, could I have one of you guys read this? That way I know you're awake. Please step up to the plate. Whoever hasn't spoken yet, just
I can read it.
thank you. That way I know you can.
Um, Few trends could so thoroughly undermine the very foundations of our free society as the acceptance by corporate officials of a social responsibility other than to make as much money for their shareholders as possible. Milton Friedman.
Thank you. And that actually is a legal principle. If you are a corporation and you have investors in stock on Wall Street, your primary responsibility is making profit for those shareholders. And the question is that compatible with the provision of medical care? Uh, Here are some of the thinkers of the time. That's Friedrich Hayek on the left from back in the 1930s, Milton Friedman, Ronald Reagan, of course, and Margaret Thatcher. And Ronald Reagan really was a great communicator. He was an actor first, and then a really well-accomplished politician. And these words are, who wants to read this? Somebody else. Um,
I can read it.
Thanks.
The most terrifying words in the English language are I'm from the government and I'm here to help. Ronald
Thank
Reagan.
you. And that resonated following the economic turmoil of the 1970s. Jimmy Carter had been elected after Ford, after Watergate, ineffectual to some extent, although well-meaning. And here was a perspective that we live with today. Um, and I think what we're going to see are some of the consequences of deregulation. Deregulation allowed these small HMO community-based practices to be competed by for-profit HMO insurers. They rapidly were able to raise capital, sell stock, were given permission to be interstate. Price controls were eliminated, and with the hope that the power of the marketplace would keep costs under control. There are numerous mergers in the healthcare industry, and the Blue Cross Blue Shield actually merged into what became Anthem and now today is Elevance, basically a for-profit. But there are some states that still have nonprofit Blue Cross Blue Shield, by the way, but many of them now have been absorbed into for-profit corporations. The practice that I was in folded as they competed with us. What are the implications? What happened to the cost of medical care as a consequence? Sometimes deregulation helps reduce prices, sometimes not. Sometimes there's anybody, are you guys aware of Enron? And the smartest guys in the room. If you're ever interested into the abuses of a public good when it becomes privatized, Enron was a corporation that provided energy to various states. It basically traded air. And the smartest guys in the room is an expression that came after. They were all in jail. It's something I would advise you to look up, the history of Enron if you're interested. In any case, deregulation really did not have an effect to lower costs or prices in the medical field. I want to share with you this slide. You'll see many slides like it. On, I guess it would be everybody's left, 1970. The United States, which is that sort of yellowish line, was in keeping. It was not more pricey than most other nations on Earth. What you're going to see is a relentless climb in prices that really happened coincident with deregulation. And it only makes sense. Have you guys heard the word monopsony yet? So if a government has control over prices, it is able to control prices. That only makes sense. Monopsony, you've heard of monopolies. Well, monopsony is when a government has its finger on wage control or price controls and can basically set prices, which is what most other nations do to an extent. We talked about the flaws in Medicare. Hospitals were keeping people in the hospital unnecessarily, providing additional procedures for fee-for-service reimbursements. And there was an effort to manage hospital costs called diagnosis-related groups. So basically, this was a program that would provide a bundle of payment for a bundle of care. So if you came in with a hip fracture, you would get 1 degree of reimbursement for the entire hospital stay. Rather than paying for the surgery and paying for the days and paying for the band-aids, hospitals would be provided by Medicare one lump sum. And that did have some effect to slash length of stay. And hospital days tumbled 30% between 1981 and 1988, which basically underlines how many of those hospital days were unnecessary. Um, the cost control was effective to an extent, although somewhat short-lived, as we'll see. And one of the consequences was hospitals needed to hire many administrators to deal with codes, and they would upcode things and put on diagnoses that may or may not have existed in an effort to get additional payment for Medicare. But those shorter number of hospital days also led to a fairly significant drop in hospital beds nationally. By the way, the United States, we talked about primary care and how we're relatively have a dearth of primary care physicians. You may not know this, but we also have a relative dearth of hospital beds. Compared to most other countries, we have relatively few hospital beds, and this was part of the contribution to that. You're gonna hear more about hospitals and payer mixes. I'm gonna skip through that. But DRGs was one governmental effort to reform that initial flaw that the AMA put into Medicare. Have you guys seen this slide yet? Anybody seen this? If you haven't, I'm happy to be the first one to show this to you because I think this is a striking slide. What you have is, and did I discuss this yesterday? So anyhow, in yellow is the number of physicians between 1970 and 2017, and in blue is the number of administrators. I think it's a pretty striking example. We saw that it start to climb with DRGs back in the mid 1983, 84. With the rise of managed care HMOs, managed care organizations, we see an exponential increase in the number of administrators, which we'll see is a pretty substantial burden in terms of cost. So, a world of managed care organizations geared towards profit developed in the United States due to deregulation. They took the brunt of employee-sponsored insurances away from Blue Cross Blue Shield and did very well financially. These managed care organizations came to provide insurance to vast numbers of Americans via their employers. Various parts of the country had what's called high penetrance of these managed care insurers, that they covered 60%, 70% of those who are insured by large corporations. United Health, Aetna, Humana, Cigna, they all made huge profits and also started to implement utilization review programs or prior authorization. We're talking about administrators. Each one of these separate corporations would hire legions of nurses and administrators to be on the phone looking at a test as to whether it would be covered or not. If a patient had a pre-existing condition, it would be excluded. No, you already have diabetes. We're not going to pay for that hemoglobin A1C. We're not going to pay for your insulin. That was the nature of the world in the 1990s. Many Americans came to hate HMOs because they had pre-existing conditions but could not receive care for it. All of this was going on simultaneously. And gatekeepers, we talked about this the other day, the conception of doctors as corporate entities was developing. We're developing fiduciary conflicts with our patients, being said that, oh, we're the hospital, which is paying out their contracts to the insurers, is finding that you're ordering too many tests, so maybe you should stop ordering unnecessary tests. Occasionally they were unnecessary. The vast majority were not. So numerous corporations started to dominate both politically as well as medically. And initially, the insurance companies had the upper hand. They had high penetrance in a particular area, And the hospitals had to basically cut back on what they were receiving until they got smart. Hospitals, which were small independent community hospitals, were losing money left and right because they couldn't get paid an adequate amount. And the stock of the major insurers was climbing. But the hospitals realized that if they consolidated into health systems, they would have the upper hand in negotiations over the cost of what they'd get reimbursed for a particular procedure. So things changed in the 2000s. The tables turned. Hospitals consolidated across the country and across regions into large health systems. And they were able to demand higher prices for their services with the corporate managed care organizations providing employee-sponsored insurance. Folks, I want you to think about this because I'm going to need to move to another room, not because of my internet, but because my friendly carpenter is here to complete the windows in our bedroom. So bear with me. How you doing, Carl? No, it's okay. I'll just, I don't think you could be that quiet. I thank you for your email. I actually didn't have a chance. So how you doing? All right. Sorry, folks, you're getting a window into how old houses need new windows. All right. So what we're seeing is negotiations between insurance companies and hospitals. Hospitals got smart. They became actually large monopolies in various areas. And now the insurances had to compete with increasing demands. And we talked about this briefly yesterday. One of the ways that they competed with other insurance companies in a particular market was by capturing subspecialists. So they made sure that they were paying those subspecialists high amounts, 200 to 300% over the Medicare benchmark rates. And hospitals responded as well. They were incented to do interventional services to get paid for those higher reimbursed procedures and at the expense of community-based services. So what we started to see were these billboards for knee replacements or cardiac surgery or other elective procedures. And as a consequence, hospital costs started to explode. Remember, Medicare was able to control costs to some extent as a monopsony. Medicaid as well to an extent. But the private insurers were not regulated in this fashion, and hospitals now had the upper hand, and they were now charging increased amounts for the same procedures. And this is the average charge to what it actually cost to do a procedure between 1999 and 2018. And what you'll see is it doubled because the hospitals could ask the employee-sponsored insurers to pay twice as much. Does that make sense? Any questions on this? It's a lot, and you'll see this will be coming up again. So we have what's called pricing failure. Hospitals were not controlling costs. And actually, if you look at where health expenditures were exploding the most, it wasn't, even though we hear a lot about, can you guys see my cursor? You able to see my cursor? Yeah. So this is retail prescriptions. We talk a lot about how the cost of prescriptions skyrocket, and they were. But compared to the cost of physicians and clinic reimbursements, and hospitals led the show with expansion of cost and inflation, far out of relation to other goods. Again, Medicare, Medicaid, and here's a comparison between payment rates of inpatient stays. Medicare and Medicaid were relatively flat. They could control it a lot more successfully than the private health insurers, which actually have gone up more recently. So, in terms of these facilities, The other thing that was happening were interstate multi-facility for-profit hospital corporations. And where you guys live, how many of you have a Health Corporation of America or Tenant hospitals? Is that in your neighborhoods? These are for-profit nationwide hospitals. I don't know about Virtua, uh, what its status is, frankly. You guys might do some research on that. But they would outcompete local hospitals and just provide and provide lucrative services. Same thing happened in nursing homes. As a geriatrician, I would practice in nursing homes that were often family run. Their culture was devotion to the patient and maintaining, an income, but not geared towards maintaining stockholders' revenues or dividends. So the world changed a lot in the past 30, 40 years. So increasing monopolization, consolidation, concentration of ownership, and control of health services was the rule. Unfortunately, folks, it looks like my internet for some reason is again unstable. Can you guys still hear me? Uh, Damn. Oh, I see moving heads. Are you still there?
Yeah, we
Good.
can hear you. You kind of, sometimes you come in and out, but it always comes back.
I'm so sorry, and this has not been a problem in the past. So okay, well, you guys have been bearing with me since 9 o'clock. Do you need a bio break? A vote on, do we need to take a break? No? Um, is this sort of making sense? Good. Because what we're seeing are dramatic changes in healthcare following deregulation. And how we get from point A to point B for our patients will be much of the future sessions. All right. So, what happened with the economy? What was happening with people's ability to get insurance during the 90s and the early 2000s and noughts? Well, the other thing that was happening with stagflation is we were starting to see a lot of inexpensive imports from Asia and elsewhere that was undercutting U.S. legacy manufacturers. Part of that was, again, with the oil shortage. My first car was a Datsun, made in Japan. It was very gas economical because I couldn't afford as an intern to pay for a gas guzzler. So multiple imports were coming that undercut the auto industry and other legacy manufacturers. Companies had to close. They didn't respond in time, couldn't compete. Some of them moved to the South where unions were rare and the employer could spend less costs on wages. And with the loss of unions, those benefits that had been gained in previous decades started to become lost. And here's just an example. Again, unions have their pros and cons, but in terms of protecting benefits, and in this instance, we're interested in healthcare, we see how the number of US workers in unions exploded during the 30s, into the 50s, and through the 50s. Again, it was only 30% of US workers, but it's still a substantial amount. And then it declined substantially. This is just comparing it to the share of the top 10% of earners in terms of income. As we know, disparity climbs in our current society. So that was one of the things that was happening during the 80s and into the 90s. Many people needed to become entrepreneurs and develop smaller businesses. And as you know, the gig economy, where people were self-employed, did not have employee-sponsored insurance, started to replace those dwindling legacy industries. And as a consequence, high benefit jobs becomes increasingly less common. Um, the deregulation also allowed for-profit shareholder-driven healthcare companies to be the predominant form of insurance rather than Blue Cross Blue Shield or indemnity insurers. And so the other thing is, as we saw, premiums were climbing. All of a sudden, after the 90s, health insurance costs to buy that health insurance was unaffordable for many people unless they got it through their workplace, and because they were now paying more to hospitals because of price failure. As a consequence, if you are not receiving your benefits through a large corporation, or it would be unaffordable to afford health insurance. You couldn't purchase it independently. And as a consequence, the number of uninsured climbed dramatically. This is one such slide. This is about 12% in 1978 of folks who are uninsured, climbing to 16%. What does that mean in millions? Well, from about 24 million to 43 million Americans went without health care costs in 2007. And that continued into the noughts until the ACA. Again, just to bear in mind, in a country where health insurance is linked to employment, whenever you have a recession, you will lose health insurance. Whereas other countries might tighten their belts during a recession and perhaps provide less services. That's a reality. If you are a country that's struggling to pay the bills as a government, you may provide less bells and whistles with your health care. You may cut back on the duration of physical therapy, or cut back on knee replacements, or cut back on other issues that are elective. That is a reality when government is the sole provider. In a country like ourselves, where basically the private markets are the providers of healthcare, every time there's a recession, unemployment climbs. I'm sorry, yeah, unemployment climbs, but along with it, uninsurance climbs. So 20% of the non-elderly by 2013 were going without health insurance. How does this get perpetuated? Why don't people revolt? How come the neoliberal perceptions of the free market and its benefits go unanswered? Well, there's something called the policy trap. And again, this is from a second book by Paul Starr called Remedy and Reaction. And this refers to the creation and funding of an increasingly complicated, costly system, by the way, that people don't understand, and that is not transparent. Well, that system satisfies enough of the voting public and also so enriches industry and industry's lobbyists to make change extraordinarily difficult. So again, a lot of people had Medicare. The older folks over 65, they vote. A lot of people who voted were well off. They were not struggling with two jobs and not apathetic about the role of their vote. So the policy trap incorporated enough people to be adequately satisfied with their health insurance to not want to make dramatic changes. I think that's changing. And again, you'll be hearing from my colleagues about current polling and current trends. But if you're satisfied with your health coverage, you're not going to ask or insist on changes. Well, 1992, there is a new election. Bush Sr. Was not reelected, the incumbent, and Bill Clinton, who is really a middle of the road Democrat, who did absorb a lot of neoliberal thought, came into office. Hillary Clinton, as a candidate, was initially, and a really bright person, was initially appointed to try to develop universal health care insurance by her husband, Bill Clinton, in 1993. And she created a ambitious Health Security Act. This would require mandatory enrollment, which is usually necessary to achieve community rating. Remember, you need a large pool of folks of the various health status, and entailed the elimination of pre-existing conditions and drug coverage. It was unfortunately complex. It was administered via regional associations rather than states, but it came at a time where health insurers had lots of bucks to spend on lobbying. They opposed it. They had effective commercials. Harriet and Louise were a husband and wife sitting at the kitchen table trying to pay their bills and decrying how this would make things even harder for them. Again, speaking to those who already had health insurance rather than who did not. And it was dead on arrival. This upper left is those commercials, those effective commercials deployed by lobbyists throughout the country. And here's folks protesting against government health care. What did come to play under the Clinton administration was coverage for children. So the Balanced Budget Act, or SCHIPS, was voted and approved. These were block grants that were provided to poorer families who did not meet federal poverty levels, but were still poor, and who were above the 147% of federal poverty that Medicaid kicks in for, who had kids. So if you're above that federal poverty level, but still below what was felt to be non-poor, you would have expansion of Medicaid. And that those block grants to states actually came to provide care for actually a substantial number of children in the US who were previously uncovered. Again, how do we fill in the cracks when we don't have universal health insurance? Well, these are the ways that we do it. What was happening during the 90s to the aughts and beyond? Again, here's an illustration of, remember, we're talking about how health insurance premiums were becoming unaffordable if you didn't have it covered by your workplace. Here's the explosion in inflation of cost of health care, insurance premiums. Here's workers' earnings during that time, and here's overall inflation. So again, this was a time of vast disparity in our society, which exists to our current age of oligarchy, but illustrated in the world of healthcare. And again, we're an outlier. Again, here's a different, we looked at a slide that looked at the 1970s where we were within the pact of other countries. This is basically just to illustrate how overall healthcare percentage of GDP spent on health exploded compared to most other nations. The average of OECD nations was 9.6%. Ours is currently up to 18%. It's nuts. And that's the world that we're living in. Hence the benefits of neoliberal policy. It's already 10:12. I'm going to touch on this stuff because, and I think you're going to see it again. This is no longer history. This is now looking at that graph of why our costs exploded as it did. And two things, prices and waste. If somebody were to ask you, why do we pay so much more in the United States than we do across the border in Canada or in Japan or Australia or Switzerland or wherever it might be? Two things, prices and waste. So what about prices? Well, we're talking about some of the effects that hospitals, monopolies had on the cost of care. Um, it is diagnostic procedures, surgeries, drug devices. This is an old slide. I tried updating this. I haven't tried doing this more recently. This still remains the case. This is looking at what it costs to perform a hip replacement, which is done just as often in any of these countries as is done in the US. And as you'll see, in the United States, it's about 20% to do a hip replacement. In Holland, it's about maybe 25% in, I'm sorry, I'm sorry, that kind of day. In South Korea, it's about 38%, etc. Knee replacements, the same thing. As a delivery or a cesarean section, all of these numbers are less than, are 50% or less, with an outlier being here in the UK for deliveries for some reason. Bypass surgery, appendectomies, angiograms, MRIs, not just interventions or procedures, but the tests we're ordering. The US is 100%. South Korea is 50% for that CT of the abdomen. Holland is 20%. By the way, countries like Holland have insurance. They use insurance intermediaries, but they're tightly regulated. So this is just an illustration of how we have had pricing failure in the US and making care unaffordable. Here's again just another graph looking at how much it costs to do an angioplasty and bypass surgery. This is more recent, 2019. Germany to do an angioplasty about $4,000, US $32,000. So this is pricing failure. Again, bypass surgery, 17,000 versus 76,000. That's gone up extraordinarily even more in the world that we're living in. Again, lack of regulation, profit to be made, and it's not the quantity, it's the cost of the service. Here we'll see the number of hip replacements done in 2017 per 1,000 people aged 65 or older. Switzerland does more. We do have a lot of hip replacements. We may do more elective hip replacements, but if you fracture something, you need a new hip. Norway's not far behind. Canada, again, so Canada is an example where tightening of the belt for expenditure on healthcare can impact on elective procedures. So many of this discrepancy is not due to hip fractures, you need a new hip, but due to how long it takes to get an elective hip in 2017. That may change. But there's no perfect system, but the point I wanted to make was the cost of healthcare is not due solely or primarily to the number of procedures done, but to the cost of that procedure. Again, this is a number of MRIs done. Germany does more MRIs, France does more MRIs than we do, but they do them at much less cost. This is in reference to the volume of services that physicians perform. Again, this is to bring home that pricing failure in the United States. Yes, Anana.
Are these is the price like are these prices including the cost of paying all those the insane amount of administrators that we have in the hospital system? And how does the number of administrators we have in the US compare to similar countries?
Perfect segue. You must have seen well, maybe you have seen my slides. The answer is yes. The hospitals do charge and cost more for those procedures, as that does play a role, but it's also so it's built into an extent, but it's also an independent cost. So both things are true. Thank you for the preface. Here we are on waste on those procedures. It's estimated, and how do you separate out how much a price is inflated because the hospital is asking for higher prices because they can, because they're a monopoly, versus I think actually the majority of of pricing is not related to the administrative waste. They're accounted for separately. But it's got to play some role. Those who have studied this, health policy specialists estimate that administrative expenses account anywhere from 15 to 25% of total US health expenditures, which is now $4.7 trillion. This is an old slide. So from a few years ago, it was estimated between 600 billion and $1 trillion. Is that real? It is real. Each hospital and office practice are dealing with multitudes of private health insurers that have various billings, various claim policies, various payment policies, all of which have different forms to complete. You're dealing with multitudes of insurance companies that each have their own policies about what they'll cover and what they don't. have their own utilization review teams that are looking at prior authorizations. Each one of these companies have their own formularies. And hospital and the practice has to research which drug among GLP-1 agonists, do I cover Ozempic? Do I cover Ribelsis? Does it cover tirzepatide? The amount of administrative waste is extraordinary. This affects hospitals and affects office practices. In fact, there's a famous study, this is real, that an average office practice has to hire administrators spending about $100,000 per year on those interactions with insurers. You would think, well, why don't you just have uniform forms between these various insurers? That would make sense, wouldn't it? And here's an example. And I think this is Ed Weisbart's slide. I stole it from him. Here you have two comparable hospitals. Duke University Medical Center has about 1,000 beds. It has more billing clerks than it has beds. This is a reality. 1,600 billing clerks. Here's University of Toronto. It has more beds, 12,000, almost 13,000 beds. It has 7 billing clerks. Does this have impact on what we're paying? The answer is, of course. So those two issues, waste and actually pricing failures, are playing a role. We haven't talked about, and you'll be hearing a lot about, how corporate insurers like United Health and Elevance, et cetera, have been able to vertically integrate with their own middlemen. So you're going to be hearing about pharmacy benefit managers and about payment cycle managers. They used to be independent for-profit corporations, now come under the aegis of the same large insurer. So all these things have resulted in huge cost overruns. And I do apologize for the internet failures from earlier. And I just want to give a little bit of a preface to the next historical sections, but drive home how market fundamentalism, business of America is business, may or may not be applicable, and I think the underline is not, to serving a society's control of healthcare costs as well as provision of healthcare. Hence, you guys are all here with Physicians for a National Health Program. And just to preface that, the next session, which with myself will be on Friday, we'll talk about how the Affordable Care Act came to be, and it did help decrease the number of the uninsured, but some of its other implications. We'll talk about, and I think Dr. Malik, one of your former colleagues who took this course, a fellow by the name of John Waters, and I think Ed Weisbart will be talking to you about Medicare and Medicare Advantage, again, which is how which is a consequence of how the private sector was engaged to expand what traditional Medicare was not initially legislated to expand. Rather than expand traditional Medicare under governmental services, they farmed it out to the efficiencies of managed care corporations and the implications of that. And we'll note that, just as we've been discussing, despite evidence to the contrary, our Congress continues to turn to the private sector to somehow control costs and improve the provision of medical care. So that's what I've got for today. And let me open this up. I will stop screen sharing if I could figure out how to do that. Uh, we're living in a challenging time, and I think much of our challenge has been getting from point A with our current crazy system to point B. But is any of this history helpful in understanding how we've gotten here? What are your thoughts living in the world that you see, and talking with your colleagues. Yeah. Maybe someone who, let's see, I think everyone's had something to say, but I don't want to pick on people. So when you're thinking about these medical insurance issues, where's your level of optimism, pessimism? Where is your perspective? And I don't want to color it.
Zach, did you want to say something? I saw your hand up for a second.
Um, if someone else wants to speak, it's okay. Or I remembered speaking to Caitlin, and she had some pretty stellar examples of difficulties in accessing patient care. So, but yeah, I don't have much.
Caitlin, I
Um,
guess,
oh,
yeah.
oh, I was just gonna say something, um, a little separate from that, but just something that stuck out to me was really, um, the quotes from Ronald Reagan and how similar it seems to what I'm hearing today and in recent years. Well, I guess honestly, always. Just kind of the fear surrounding whenever something like universal healthcare is brought up, when, according to the polls, most Americans on both sides do think that, it's worth looking into, or do think that it would be beneficial. And when you just bring up the concept that everyone should have healthcare, or everyone should be able to afford necessary healthcare, there's not many people in America that disagree with that. But then I feel like the conversation is always shifting towards, oh, but if we do this, then it's America is going to go down a dark path and we're going to become a communist country. And it's just always throwing around these buzzwords to kind of create, I mean, to fearmonger essentially. So then the whole issue becomes clouded by just fears of socialism and communism, when I feel that many Americans probably don't know why they should be afraid. It's just kind of buzzwords used by, I mean, even both sides to just stir up fear, and then it's just what's associated with some of these some of these ideas and projects such as universal healthcare. So for me, it's encouraging knowing that according to polling, there's a lot of people who in America, the majority, I believe, are interested and think it's a good solution. But I'm also discouraged just because of the way that the conversation is always shifting to something maybe that it's not really about. So it's just more like, I don't know how realistic it is in the current state of our government to implement it, but I know that, the people seem to be interested in it. It's just kind of that disconnect. Does that make sense?
Totally. What are folks' thoughts about what Caitlin just said? Yeah, Ariana.
Yeah, I definitely resonated with what Caitlin just said. And my thoughts were wondering that if people knew like our comparison of prices, like all of those graphs that you're comparing the prices of of our different procedures compared to other countries did stick out to me. Like it seems that people in higher power like tout off the US as being like the most powerful country in the world. So if that is true, why are things in our healthcare system much less optimal for our patients than they are for other countries? Like if they can do that, why can't we? And so now I'm kind of wondering, is there a poll some sort of data that shows like, does the populace know of this information and actually know of like the waste that you were speaking of? Because I feel like if they did, they would be on like the side that this doesn't make sense, which is where I'm at.
Mm-hmm. Why do you think Well, let me rephrase it. What entities, what forces at play, what stakeholders have been successful at both obscuring that information that you're learning about and presenting the threat of government healthcare? What are the forces you think that are generating that? Where is that coming from today?
I'm guessing from like the people who are profiting off of like the privatized insurance industry, like not just those companies themselves, but also the people that are like um maybe investing or people like receiving like endorsements from them. And so those are the people in higher power. So they're going to feed us the information that like may benefit them the most and not us as lower people on the totem pole.
For sure. This is the influence of large dollars. Yeah. Mackenzie.
Yeah, to kind of build off that, I also think about it a little bit from the perspective, obviously, all the people that are profiting off of it, but also kind of the politicians. I've been very interested in like the polarization of the country politically, and the background behind why people are so motivated to do that. And it's more about like keeping your current electorate than it is swaying independent voters. So like really, enraging people. And if you have a topic like this that it's really easy to enrage people about because they already have the foundation going back 100 of years, if you make them scared enough of it, they're not going to vote for the other side because the other side supports that. And they're so scared of that that they're going to vote, they're going to stay with you, they're going to vote for you because you've made that such a terrifying, you know, proposition. And so now it's you don't want to change your mind on it because then why would they vote for you if they're not so scared of the other side for that is kind of one way that I think about it.
Sure. The distraction by red meat topics like immigration and the like. So, and something to think about, how might we counter detail or counter advertise the necessity for changing the system as it exists? And I think that's an important consideration to keep in mind as this course goes on. Zachary, yes.
I just wanted to clarify something. It's not the position of the AMA, and I'm sure they've lost power, it's like centralized lobbying for physicians, but it's not their policy that they want like Medicare for all or any type of like single payer program, right? So physicians, if that's the case, it appears are complicit, and we serve as one of the primary benefactors of increased costs of
It's a
healthcare.
very interesting, so thank you for bringing that up. What is the role of organized, quote unquote, is there such a thing as organized medicine anymore? But so of interest, I'm an internist, so I have the American College of Physicians. They have come out as a lobby for internists. They have come out and made white paper reports and statements actually in favor of a national health insurance program. Family medicine, the same. Pediatrics, supportive of the same. These are these smaller sort of primary care subspecialty programs. You are correct. The AMA is not supportive, has not quite gotten there. Because there's 51% of doctors now who are younger and supportive of a national health program, they're no longer saying that they are opposed to a national health insurance, but they're not coming out to support it. And you are absolutely right. They have lost a huge amount of power and respect, I think, as well among physicians because of their complicity. But what they still have power is that relative value committee that sets the reimbursement for various subspecialties, primary care services versus other services. So no, it's an interesting point. Terrace, yes.
I think in the US still like universal healthcare is still associated with like super socialist communist notions. And I remember like I forgot what year there was, but like when Bernie and Warren were running, like I think they were the only proponents of a single payer system among all like the 10 candidates that were running. I was like wondering like how you think we can reframe the issue so that more moderate Democrats can, like it can be more appealing to more moderate or more conservative liberals?
I think you're right on target. The absence of protecting our societies and our communities with adequate health care falls on both political parties. It is not unique to the Republican Party. It really is painted with a similar brush on both sides. And a lot of it has to do with lobbying and with apps. One of the things that Bernie Sanders was strongly appealing to people to look at is the absence of regulation of campaign financing, which allows corporations to spend huge amounts of dollars on PACs to basically influence advertising. So one of the questions is if that exists, that's not going to change. The amount of political power that large corporations and profitable organizations make is not going to change in the near future. The question comes up is how do we counter that with other alternatives? How do you change your mind of of people who are swayed by those ads on their social media? How do you make influence on people recognizing what's going on? Um, and I think hopefully getting a younger, less lobbied group of Democrats into office will go a long way towards making a change in that, and hopefully we'll start to see that. But all important points. Yes, Lauren.
Yeah, I think something that like that question makes me think about is something that was mentioned in the lecture that you gave was this idea of the undeserving poor. And that's something that I feel like I still see and hear a lot, in that people do want these benefits, but they only want it to people that they think deserve it the most, or who are like putting in the work for their taxes and whatnot. And so obviously I feel like that's like a wide misconception. It's not like people are poor just because they don't want to work or just because they're lazy and want free benefits.
Mhm.
So I think in order to kind of combat this, like, and then it also becomes like this just struggle between like the middle class amongst themselves. Like they find ways to like have an us versus them mentality, even though we're all like relatively in the same social standing or socioeconomic standing. So I wonder if the best way to counter that is to just help people become more aware that this exists, which I think is also happening, where obviously like the younger generations, I think, are more cognizant of how much advertising and how much the wealthy do play a role in the way we perceive ourselves and each other. Um, but yeah, I think, and then it like I'm like kind of running on tangents, but it also kind of plays on this motto of like America being like a land of the free. So what does it really mean to be free? It means like you get to put like whatever you put in is like what you take out. Um, I think that's like the mindset of like definitely my parents' generation. Um, and so I think we have to start thinking about how do we change this idea of what it means to be in a free country. Um,
Mm.
I think personally, I also don't really see it happening in like the near future. Maybe not even my generation, but I think it's moving towards like a positive, um, an optimistic way. I think seeing more and more people like just in my own class or among the younger generations, I think it'll hopefully shift towards a mentality where we think about the public good instead of um, individual risks and rewards.
Sure. You've said a lot of really important issues. And as to the latter point, sometimes political changes happen cataclysmically and in reaction. We saw that with the stagflation of the 1970s, and sort of the liberal world of Medicare and Medicaid, the Great Society, suddenly flipping over to that of the neoliberal perspective of Reagan. We might see a subsequent change to this administration. We can only hope. The other thing that you mentioned at the outset, which is the continued bias and misunderstanding of why people are on Medicaid, is essential. The vast majority of people on Medicaid, by the way, come off Medicaid. So Medicaid is often not a long-term safety net, but a short-term life preserver as someone's lost their job, as someone has children and they can't maintain a position. Again, our linkage with employee-sponsored insurance makes us very vulnerable to losing that healthcare insurance if something happens in somebody's life. And again, Ronald Reagan was part of his appeal to people are talking about red meat distractions. Oh, the welfare queens. Oh, these people are collecting their health insurance and their welfare, quote unquote, uh, um, inappropriately and outlandishly. Whereas the vast 99% of people who were receiving it were barely getting by and needed it as an essential safety net. So these perspectives all are tied in together with American myths of pulling yourself up by your bootstraps and by being, independent frontiers people that are not dependent on one another in a community. All these issues are at play. So I think thank you for your thoughts here.